So I think I'll start the meeting by welcoming everyone and appreciating your presence here at the session, the last session of the day. Many of you have been in session since morning, but we appreciate that you're still here with us and ready to participate in the trauma and injury session. It's a great privilege for me to moderate this session at the World Health Summit, the regional meeting for Uganda. And maybe just to introduce myself, I'm Dr. Olive Kobsinje. I am a senior research fellow at Makerere University School of Public Health. I'm an accident and injury surgeon and injury epidemiologist. And I'm also a distinguished fellow of the George Institute for Global Health. And I also chair the board of the Road Traffic Injuries Research Network. It's a great honor for me to moderate this session. And I have a co-moderator, Dr. Claude Martin, who will introduce himself shortly. But I'd like to also acknowledge the very generous contribution of the AO Alliance Foundation. They are the sponsors of this session. So I'll invite Claude, if you would please introduce yourself as well before we get the session underway.
Good afternoon, everyone. Thank you very much for staying the course. It's tough being the last presentation and the last day of the actual meeting, and hopefully you'll get as much out of it as we've gotten in terms of preparing this webinar. My name is Dr. Claude Martin. I'm a Canadian trauma and orthopedic surgeon. I work as the managing director for an NGO that is based in Switzerland, who is dedicated to improving the care of the injured in LMICs, low and middle income countries in both sub-Saharan Africa and in Asia. We're very happy to be able to sponsor this webinar. And we hope and know that you'll end up with a few lessons learned and a few pearls of wisdom to advance this very neglected epidemic of caring for those that are injured, especially in sub-Saharan Africa. Olive, I turn it back to you, and I look forward to co-moderating this session with you. Thank you.
Thank you, Claude. So the session is on trauma and injury care for the injured in low and middle income countries, and we'll be looking at how far we've come and remaining challenges. And to do this, we have an outstanding panel of specialists. When you hear me introduce them, you'll be amazed. You'll see why we're really excited to be able to share this session with them, to have them address the session. So I'm going to start us off by making a few general statements about injuries. But maybe we'll quickly go through the actual session objectives. So we would like for this session to highlight the need for increased investment in prevention, in injury prevention by low and middle income countries, to determine how emergency care systems can be prioritized and set up for success, and to explore the impact of trauma systems on the outcomes of patients suffering injuries. So one of those things that I'll start off with is that injuries is not one disease entity. And it sounds like a redundant statement, but actually, because it's so heterogeneous, it's all manner of things that are thrown together as injuries. You know, we have poisoning and falls and road traffic crashes, drowning, and each one of these is really an entire disease entity. And the causes are just as complex. So the causes of these injuries really impact every aspect of our lives. The way we travel, the way we work, the way we play, the way we sleep, where we sleep, the way we love or don't love. And as a result, we find that this complexity maybe results in the focus being divided really. We find that these injuries are the result of decisions and actions that are taken by individuals, by the communities, by countries, or internationally. They, for instance, determine whether we should produce guns and market them, whether we should import secondhand cars, or whether we should have a swimming pool in our home. So these are all very diverse, and they then come together in a pot that's called injuries. And so we begin to see why they might not be as quick to prioritize as one might imagine based on the burden. And maybe this is something that many of you have seen, the fact that it's a multi-sectoral problem, that it impacts very many sectors and relies on many sectors to provide solutions. And so when anything involves very many players, you have both an opportunity and a problem. You have the difficulty of coordinating so many sectors, and yet it is essential if we are to succeed. So while the advocacy for injuries has been going on for quite some time, I think it started to really pick up around the early 90s when a World Bank report highlighted the fact that injuries weren't just a health problem, that they were actually a development problem, and that many of the interventions that have to deal with injuries, especially their treatment, that they're actually very cost effective. But in 2012 is when the global health estimates actually highlighted that injuries, that deaths as a result of injuries were surpassing those due to HIV, tuberculosis, and malaria put together. And that was really surprising for many people. Now, one would think, so if we look at, so what are those injuries that in 2012 were actually stripping, far outweighing those from the big three? And we see that there are injuries from violence, there are unintentional injuries, there are all manner of, and we see that even back then, road traffic crashes, road traffic injuries were nearly a quarter of all the injury deaths in the world. If we fast forward and we say, so what was the pattern in 2019? If we put 2012 and 2019 on the same scale, we see that some interesting differences, some important differences have actually happened over that period of time. One of them is that if we look at road traffic crashes, so as a proportion of all global deaths, road traffic injuries actually increased from being responsible for 24% of deaths to being responsible for 29% of deaths. But then we also made some gains. For instance, we see that poisonings and burns and drownings dropped some. So while we were saving more lives from those three, for instance, the proportion for road traffic injuries actually increased. If we think about 2019, which is very close to where we are, and we say, so what kind of injuries were we seeing? We see again that we have violence, we have all manner of unintentional injuries, and then we have 29% of those being a result of road traffic injuries. If we say, well, let's pull out Africa and see where it's at in comparison to global data. So we see again, interesting differences. For instance, road traffic injuries. So while globally, 29% of all injury deaths were a result of road traffic injuries, in Africa, the percentage is much higher. We see the same thing happening in poisoning, but we also see that in terms of falls, maybe Africa is doing somewhat better, although we also acknowledge that maybe the data are not as good. So if we just look at those data for Africa for 2019, we see some interesting patterns. So we have a quarter of injury deaths as a result of violence. So that's suicide, homicide, and war. And we see 37% as a result of other unintentional injuries. But look what's happened with road traffic injuries is that in Africa, in the African region, 38% of all injury deaths are a result of road traffic injuries. Meaning that if we are to do a whole lot to dent this for Africa, we are going to have to address road traffic injuries as a cause. Now, as I said, injuries are a very heterogeneous lot. But regardless of how one is injured, they all have a final common pathway. We get to the point where we need to provide care for those that are injured. And so whether they've been run over by a car, whether they fell out of a mango tree, or whether they swallowed something they shouldn't have, ultimately, we want to be sure that we care for the injured and that we create systems that are going to ensure good outcomes for those that do not die instantly, that are able to get to care. So in this session, we are going to do two things. We are going to look at road traffic injuries in Africa and how we can reduce them. And then we're going to look at how to improve care, as I said in the objectives of the session, how we can make we can develop systems and sustain them, systems that will result in good outcomes for those that do get injured. So with that very short introduction, I'd like to introduce our first speaker. And as I said, we have an amazing panel. So our very first speaker is Miss Tawia Ado Ashong. Tawia is a civil engineer with more than 30 years of experience in the management of transport infrastructure projects. In the World Bank, where she works, she has led the preparation and supervision of transport projects in South Asia and in Africa, and she has promoted road safety. Tawia is the pillar lead for road safety in Africa Transport Policy Program, a donor-funded program in the World Bank that works on sound transport policies for the region. Within the Sub-Saharan Africa Transport Program, Tawia has spearheaded the road safety agenda in Africa, building institutional capacity to manage road safety through institutional strengthening, policy formulation, building of monitoring and evaluation capacity, and improving road safety data management. She was actually instrumental in the establishment of the Africa Road Safety Observatory. Some of you will be familiar with that. And this is a network of the African road safety institutions and partnerships that will be monitoring Africa's road safety performance over the coming years. So if we want to find out how we can make Africa's roads safer, Tawia is the person. So please join me in welcoming Tawia to address the meeting.
Thank you very much, Olive. Can I share my screen?
Please do. We still don't see it.
Just a second.
So your camera is working, but your sharing is not working.
Okay. Oh, hold on again. Let me see. Is it working now?
Okay, that's good.
Good.
Right.
Can you see the screen now?
Yes, we can see it.
Okay. Good, everybody. Oliver's already introduced me, so I'll not really go introduce myself, but I'll just say my name is Syria, and it's a pleasure to be here. I'll take you through the presentation from the perspective of so we'll sort of look at the problem, the magnitude of the problem in Africa, some of the challenges that we are facing, and some of the solutions that we think, and the way forward that we think would solve the problems. So the magnitude of the problem, the chances of your dying in a road traffic crash depending on where you live. And as you can see, that Africa has the highest figure. Oliver has mentioned this already. That's 26.6 deaths. Global average, which is 18.3. And then compared to the averages in other countries, ranging from 9.3 in Europe and to the sort of the other highest, which is the Eastern Mediterranean, which is 19.9. So the probability of your dying on a road in Africa is much higher than in any of the other regions. Africa, like the rest of the world, is witnessing this road safety crisis, and our deaths are more than 3 times what is pertains in Europe. The past 30 years, the deaths due to road traffic injuries have grown by more than twice the global increase across the world. Every year in Africa, we're losing about 300,000 people on the roads, and we actually literally have only about 2.3% of the world's vehicles, and almost 20% of the world's the global deaths on the roads. So if you look at the situation in Africa where these are, as the economies grow, infrastructure will expand, whether this trend is going if we don't do anything about it. So these 300,000 people dying a day translates to dying a year, translates to about 650 deaths a day. Most of these, about half, are vulnerable road users, which are pedestrians, cyclists, motorcyclists, and often young children. We found out that men are 3 times more likely to be involved in road traffic crashes than females, especially in the most productive age group, which is between 15 and 49. And the combined burden of the non-fatal road injuries in sub-Saharan Africa exceeded 14 million healthy life years lost. 5 of the countries in Africa, Nigeria, Cameroon, Ethiopia, South Africa, and Uganda, half of those injuries and deaths. And these link to increase in poverty in these countries and across the globe, across the continent. These couple of charts just show where we are in terms of how Africa is addressing road safety. There are very good laws around, and there are very good practice laws which can be adapted in Africa. But as you see, out of the 51 countries in Africa, only 15 have great laws on seat belts, 8 great laws on helmets, 8 on speed limits, only 3 on laws around driving under the influence, and then 1 each around the UN vehicle safety standards and the child restraint laws, which already shows the fact that we're not addressing this issue as seriously as we should. Good laws lead to good enforcement and help reduce the issues on the ground. And this is something that we're not really addressing well. The other chart, I just wanted to show again how the different users and the magnitude of deaths amongst them. And again, you can see that pedestrians are the ones who are most likely to be killed. Though car occupants is also quite high. Based on the data that we have, motorcyclists seem to be a much smaller percentage, but this is something which is increasing over the years and over the days. And we also believe that the figures are underreported. So actually, it's a bigger part of the problem than what we are actually experiencing and showing on these charts. So what are the causes of the road safety problem in Africa? I think the first one is that we have we actually do not really have a complete understanding of the depth of the road safety issue, because it's very much underreported. The crash recording systems, based on what the estimates that are that WHO makes according to what is reported by the countries, there's up to a 50% gap, and very few countries have computerized data systems. There's a poor linkage between the health sector and the tend to collect the data. And so there's often gaps and data drops in between. So even the figures that we have are severely underreported, which also means that of the problem and some of the solutions that we are putting to the problem are not necessarily what needs to be done. Then a lot of national health and demographic surveillance systems are rare in Africa. Very few countries have solid CRVS systems. They're not linked to the police. So you go and you find that somebody who dies after the crash has happened on the road is not recorded in the police system, because the police system is not linked to the hospital system. And so the data is weak. Then we have problems with information, which are across the continent. Enforcement, a lot of the police enforcement is focused on other, and road safety is not necessarily a most important issue for them. And you find out that when there are traffic police, they are not a permanent force. They tend to be switched over and moved, and then the new people have to learn again. And road safety is just not taken as seriously as it should be, as the other areas of crime and the police enforcement issues are taken. So it creates a big gap there. The other challenge about road safety is a multi-sectoral issue. It's not just transport, it's health, it's education, it's security, the police, as we said, and there tends to be very little coordination between these different areas. People prioritize it differently. There's nobody really taking and linking them together. And so the responsibilities related to road safety are not necessarily put on as a priority, either at national level or at local level. The countries which do have lead agencies, there's some countries which do have lead agencies which deal with road safety. The lead agencies are often not properly empowered. They don't have the proper legislative underpinning to make them do their work properly. And they don't have the capacity, and often they're underfunded. So they're not able to do the work that they would like to do. So just quickly going on to what I think are some of the areas that we can look at to helping improve the situation. The first one is to strengthen these institutions. If we have a good road safety agencies who are leading the charge on improving the road safety, and they are properly empowered, they have the political commitment, they are funded properly, we're able to give them the capacity that they need to do their work, then they also find a way of making sure that they link the different sectors, public health, transport, finance, law enforcement, and private sector. That will be the beginning to getting some of the outcomes that we would like to see. The second is preparing a national plan of action. Basically, you need to know where you're going, how you're getting there, and what the role of each of the stakeholders are to improve the figures. Setting realistic targets, and these should not be done independently of other national development plans. Often road safety is sort of taken as an add-on. But from my perspective, for instance, as a transport specialist, a transport civil engineer, I see that road safety should be integrated in the work we are doing on providing transport infrastructure. And it should not be just an add-on. So when we are building roads, we should be building safe roads. And it should be thought of that way right from the beginning. One of the key areas that we think need to be improved is the issue of data. And as I said before, even though we quote these figures, we really feel there's a sense of underreporting, and not just underreporting, not being able to really understand what the depth of the problem is and how the problem should be solved. So the improvement of data quality and improvement of data management, such that we have used digital systems and make countries' road safety efforts more aligned to more quality data, then we'll start to be able to look at what the proper data-driven solutions to the problems that we were experiencing in our countries. Olive mentioned the Africa Road Safety Observatory, and this is one of the areas that we would like to focus on to improve the country's data quality, improve countries' ability to analyze the data, improve countries' connections between the vital registration systems and transport, the different data collectors, and then also work on a a continental level to ensure that we are working together, understanding the continental, the regional problems, and seeing how we can share expertise and experiences across the region. And and so that we can start having proper data-driven, evidence-driven policies being implemented in the countries. Other areas that I think we need to look at are creating the area of advocacy. We still need to continue blowing the road safety horn and making sure that people understand that it's a huge challenge. It's costing our country's economies. And it's one of these problems that can be solved if people work at it. We need to make sure that we cost our systems, as I said before, that we properly resource them, then we bring it into the sustainable transport agenda. So we're not just looking at it as an independent area. We need, the final two things, I think, are things that, the final 2 or 3 things are things which can be done whether we have the data we need or not, because these are sort of quick wins. They're sort of areas which, if you work on these, you will definitely improve the road safety situations in your country. So the first area is to look at the quality of infrastructure. We need to see that roads are designed for the speed limits. We need to see that roads are designed to take the fact that we have different road users, pedestrians, motorcyclists, cyclists. We need to make sure that the infrastructure is designed in such a way that each of these people are taken into account. We need to also address the quality and the management of vehicles in Africa. UNEP, the United Nations Environmental Programme, has recently come out with a study. 93% of the vehicles in Africa are imported from the West. The quality is not assured. Sometimes the West are exporting vehicles that they will not use in their countries, both in terms of the environmental issues and also the safety issues. So we need to work systematically to ensure that the vehicles which come onto the continent are of a quality which, if there are crashes, the people are protected. And then we need to also make sure that our vehicle inspection and management systems are robust, so that the fact that we are bringing old cars does not mean that we're not maintaining and looking after them properly. Then there are 2 very quick wins that I think we could look at straight away, and these are things around speed management and helmet wearing. There's so many studies which show that the slower the speeds, if there is a crash, the less likely the person is to be seriously injured or to die. So how do we quickly put a speed management program across the continent, especially in our urban areas? Make sure that speeds are limited around vulnerable areas, like around schools, but also making sure that speeds are limited along the highways and so on, such that when crashes happen, the impact of the crashes are less. This is something which can be done with or without statistics. And then the second one is around helmet wearing. There's an explosion of motorcycles across the continent. It's not going to go away because the motorcycle fills the gap of providing that last mile for a lot of the less fortunate and less wealthy people in the continent. So again, the figures and the statistics would show that with a good quality helmet, if the crash does happen, you're less likely to be injured. So there's this putting helmets into place, good helmet policy program, and a quality helmet policy program into place. We can already start addressing some of the issues which, without having the requisite data and the requisite policies in place. I think I'll end there. I think that that open to questions, then I think things can be picked up later on, depending on what the other panelists say. Thank you for this opportunity, and it's good to be here with you. Thank you, Olive.
Thank you very much, Tawia. Yeah, it's a big problem, and you did highlight where the major issues are, but you also gave very clear proposals on what can and needs to be done. Some of those, I think, are cross-cutting, and we've seen them in a number of areas: leadership, data and evidence, coordination. And I think we'll come to some of the details when we get to the discussion session. It was interesting, you say we need to figure out how to slow down people in Africa. A lot of times we think we need to speed up, but now we need to figure out how to slow people on the road. And I think that is something that we're going to probably come back to. I'd like to suggest, and I already see a question in the Q&A, I'd like to suggest that we put questions in the Q&A. Claude and I will keep a finger on them and bring them up during the question and answer session. So rather than break up and interrogate one presentation, we'll do question and answer session at the end. So I'd like to quickly move on to the next presentation. This now we are going into how do we care for those that are injured. Our first presenter is Professor Lee Allen Wallace. I think those of you who have been in or around emergency care, emergency medicine would recognize this name. Professor Lee Wallace works with the emergency care at WHO's headquarters in Geneva. Before that, he was the head of emergency medicine for the Western Cape government in South Africa, and he was professor and head of the Division of Emergency Medicine at the University of Cape Town. Lee is past president of the International Federation for Emergency Medicine. He was founder and president of the African Federation of Emergency Medicine from 2009 to 2016. He is the editor-in-chief of the African Journal of Emergency Medicine and has authored several book chapters and around 300 journal articles. He edited the Oxford University Press AFEM Handbook of Acute and Emergency Care. I think many of you who work in this area would have seen it or probably use the book, have it on your bookshelf. The man that wrote that is going to address us just now. And he's been involved in the development of emergency care systems in many countries. Professor Wallace is going to be sharing his time at the podium with Dr. Ghebreyesus from Ethiopia, who I believe is going to give some examples of the WHO resources for care of the injured that Professor Wallace is going to address. So join me in welcoming Professor Lee Wallace. Lee, you have the floor.
Thank you, Olive and Claude. Thank you so much for the opportunity to be here. Hope you can see my title slide on the screen.
Yes, we can.
Okay, perfect. So as you said, the time that we've got is split equally between the two of us. But I'm going to keep the slides on my screen, and we're going to do the new old-fashioned way of someone saying, next slide, please, and just to minimize the interruption. So, great opportunity to share some of the WHO products. Thank you. As you said, I'm now with headquarters in the Clinical Services and Systems Unit, dealing with emergency care. But this few slides, we'll be looking at the resources that are coming out of WHO that specifically help the injured. But as you'll see, and as I'm sure everyone on this call knows, if you put a system in place to help the injured, you, for free, get a lot more from that, where you help people with asthma and stroke and all of the other conditions. So let's jump into it. What was the motivation behind where we're at now with the tools and so on? So over the last 15 years or so, there's been a number of World Health Assembly resolutions. So in the same way the United Nations has the General Assembly, WHO has its assembly, which really gives it the mandate for what it should do for its strategic plans for the next years. And in 2006, 2007, there were a couple of really important emergency care and injury care related resolutions, which we're going to hear from Charlie Mock as the next speaker. And Charlie was with WHO at that time on trauma care, and he drove the production of these three really great resources. And Charlie's talk is going to cover those in more detail, so I'm not going to go into them. But these were the first sort of injury-facing products out of WHO, the guidelines for essential trauma care and pre-hospital systems, and then trauma quality improvement program. But that was followed over the years with more resolutions, which has been excellent. And with the drive of several countries, including Eswatini and Ethiopia, in 2019, just before COVID came and really, upended a lot of what we do. There was a resolution about emergency care systems, ensuring timely care for the acutely ill and injured, and that resolution really spells out detail of how countries can strengthen their emergency care system. And it gave WHO the mandate around both supporting countries with data and technical products as well. So we're going to look at some of those. The other mandate for strengthening injury care, it comes from, and originally we had the Millennium Development Goals, as you'll no doubt know, there were 8 of those, but they were replaced by the Sustainable Development Goals. And there's 17 of them, and each of them has targets. And there are 10 targets that we're interested in from a clinical care point of view. And these 3 that you can see now are injury care related targets. For instance, halving road deaths and injuries by 2020. That, for a number of reasons, wasn't achieved, and there's a new target around that for 2030. But all of the other targets have a 2030 orientation. But if you put an injury care system in place, as I said at the start, turns out you get free care for all of the other sorts of emergencies. So pediatric emergencies and maternal emergencies and infectious diseases and non-communicable diseases. So we really are looking at one system for injury care and emergency care within one. Given that there's a series of mandates from countries and from the Assembly and from the Sustainable Development Goals, one of the first things that WHO did when it started focusing on emergency care more widely was develop an emergency care system framework. And you'll see that in the second half of the talk. We use that system framework to derive an assessment process which allows countries to develop their national priorities. So all of you recognize the logo of a particular Ministry of Health there. So WHO works with the Health Ministry to identify stakeholders in the country who are involved in the emergency and injury care system. And they complete a survey, and then we analyze the survey results and the data. And we come together for a 2-day consensus meeting where we debate the findings. And you come up with a series of action priorities for the country to prioritize in its health strategy for the next 3, 5, 10 years, depending on the speed of implementation. So we've done that in over 40 countries now. And in Africa, you can see the list of countries that have completed an EXA. You'll see a little bit more about the activities that have followed from the EXA in these countries in the second half. But what's important for the tools that I'm going to mention is that we take those 40 or so country assessments from across the world, and we see the same action priorities again and again. The same issues come up, and we use them then to help us determine as an organization what our priorities should be. So these action priorities that have come up from the assessments are lumpable into 5 thematic areas. So policies to improve access to injury care and emergency care, clinical protocols such as triage, training, standards for quality and data, and then pre-hospital systems. And then there's a toolkit that follows from that. I'm going to show you some of the tools, particularly the ones that pertain to injury care. But all of these resources become available for free to countries to implement, and WHO supports if the country needs that support or requests that support. So for instance, the basic emergency care course, you can see at the bottom of the slide, it was produced also with ICRC and the International Federation for Emergency Medicine. So it's a very frontline provider oriented course. So anywhere where people with acute injury or illness present and first contact, so in the pre-hospital environment and in the hospital, and it teaches a structured approach, the same that you would get from, say, an advanced trauma life support course, but at a more basic level. And it's been rolled out to thousands of people so far, obviously interrupted by COVID. But we're very excited that this course will be one of the first courses launched on WHO Academy, the new platform flagship platform that's going to be rolled out later this year. So there's a lot of work going on right now to make that a reality. Then triage. So emergency triage protocols, there's one version for the pre-hospital environment, one for mass casualties, and then in hospital for children and adults. And there's a 3-color, and countries can adapt it to a 4-color version if they wish. And so it would, for instance, in the red category, defines high risk trauma. So if you have certain injury mechanisms, then you should be prioritized red and taken straight to the resuscitation area in the hospital. So this is obviously a very important part of, I'm sure everyone on the call will know the value of triage in emergency flow management. Checklists save lives. We know that. We know it in the airline industry, we know it in surgery, and now we know it in emergency care as well. And we have a non-trauma checklist, but particular interest here, there's a trauma care checklist to do in the resuscitation room, when you finish your primary survey, again when you finish your secondary survey, before you leave the patient. And we've had research on this that shows a significant reduction in mortality, even if this is the only thing that you implement. Checklists really remind people things that they would miss otherwise. Then we have standardized charting. So for injured patients in resuscitation, turns out that instead of writing road traffic collision, 60-year-old male sutured go home, if you get clinicians to write notes in an airway, breathing, circulation format, they start to think in that format. And if they start to think in that format, they start to behave in that format, and it changes their clinical behavior. So these standardized charts are something that we're really excited about trying to use. Now, clearly places that have well-developed charts don't need to use it, but a lot of places we've found just use plain paper for their clinical note keeping. So there are standardized charts for injury and for non-injury. And the injury one ties completely into the International Registry for Trauma and Emergency Care, which is it's on the DHIS2 platform, which is used already by many ministries throughout Africa. So it's basically freely available to hospitals. All they need is the infrastructure to enter the data, and it links completely to the standardized charts and is supported by a minimum data set for injury, which has been agreed by global consensus. So a registry out there to drive your quality improvement initiatives in trauma care. WHO is supported by a long-standing alliance of multiple partners from across the world, the Global Alliance for Care of the Injured, and they've helped to produce a number of these products that I've shown you already. But also the picture I'm showing you now is the title slide of an advocacy slide set. So if you had an opportunity, for instance, to meet with a health policymaker and you wanted to persuade them why they should invest in their injury care system, this is freely available on the WHO website. You can just download this and use it as talking points. And it talks about the cost effectiveness and the clinical effectiveness of the trauma care system. Of course, Claude is from AO, and we want to thank AO Foundation for their generous support around the Getty initiative that launched a couple of years ago and has driven a lot of emergency and injury care initiatives across multiple countries, and you'll hear a little bit about that in a second. But just a couple of other things that are coming up. I've just shown you some of the tools that already exist and are out there if you want to use them. We're bundling those tools together with a number of other, all the EMS work, the pre-hospital care resources that have come together. We have essential medicines lists, essential equipment lists for emergency units, training recommendations, so on. They're all coming together, all the different parts, into something called essential resources for emergency and critical care. So we're expanding into the critical care environment as well. And we're hoping very soon to have this resource out, a manual for policymakers and facility administrators to know how to set up their services. And the other thing to help drive that, we've started with injury, but we'll repeat this for maternal emergencies, a couple of other conditions. We have 5 in mind, but, and I'm sorry, this is, I found it a little bit difficult to show this. This is built currently on the Prezi platform, which allows you to dive in and out of these clicks. But it allows us to walk through with policymakers or administrators. So if, for instance, a decision maker in the ministry wanted to know what trauma care should I provide at first level hospital, we use Laska, who's a victim of a road collision, and we walk through her journey through the health system. And each one of these buttons that you click on, you go into a deeper level and a deeper level, and it'll take you down to what sort of injury care should be provided at this hospital. Okay, I want to know more about it. What sort of emergency injury care in the emergency unit? What equipment should I have? What skills should be there? What medication should be there? You can do the same in the operating room. You can do the same in the intensive care. So this is coming out soon. So between this and the essential resources, we think we're going to be able to offer a really comprehensive bundle to both to clinicians so that they know what they should have and they can advocate, but also to policymakers so that they can strengthen the system. I know that was a lot I've run through, but I'm going to start being the slide operator now, and I'm going to hand the microphone over. Thank you.
Thank you so much, Professor Liwalis. My name is Alenta Gabriel-Jesus. I'm an emergency physician, currently working as Director for Emergency Injury and Critical Care Directorate at the Ministry of Health Ethiopia. I'm just going to briefly touch some of the points on what it actually looks like at on the ground level. So next slide, please. So we all know this emergency care systems framework. We've actually used it for several of the advocacy sessions whereby we actually mention that emergency care or injury care is not only the care in the facilities, it actually starts from the communities, and there's a lot of work at the scene and during transport. And also the acute care continuum also extends through to the facility care and the early inpatient care as well, and creating access and quality improvement in this regard is very essential. Next slide, please. So when it all started, considering the immense need for frontline capacity building in emergency care, WHO and ICRC have developed this BEC, Basic Emergency Care course, which have been proven to be very acceptable, highly acceptable, and also increases the confidence level in the skills and knowledge for frontline providers. And using a flipped method of focusing more on the skilled session has proven to be very effective in improving the capacity at the frontline workers for the care of the injured. So these initial efforts have been initiated in Tanzania and Uganda. These efforts have spread across the African continent and under the Global Emergency and Trauma Care Initiative. Uganda has implemented the second phase of the GATE activities. Zambia is about to launch the GATE activities. Tanzania also continues with the BEC implementation and also supporting the rollout in the neighboring countries. Ethiopia, also being one of the countries, has a lot that I'll discuss on regarding the implementation of this Global Emergency and Trauma Initiative, one of which is the BEC course, the BEC toolkit implementation, as well as the pilot implementation of the International Registry for Emergency and Trauma Care. Next, please. So as we can see here, a lot has been done in the Afro-African countries in the Afro region as well as the Emro region. All the countries have done the emergency care systems assessment. Some are in the stage of implementation of the toolkit. I can speak for Ethiopia that the toolkit implementation is underway in 10 primary hospitals, 6 of which have actually started the actual implementation. The BEC has also been given widely. Ethiopia has trained over 3,000 frontline providers in this regard. The registry implementation is currently undertaken in Ethiopia and Uganda, as well as also DRC and Eswatini, Ethiopia, and Zambia have also done the facility level emergency assessment, which is also very important in crafting interventions at the ground level.
Next, please. So it also extends to other regions in the African countries in the Emerald region as well. So they have done the EXA, the toolkit implementation, as well as the BEC course. Others are also in the pipeline doing so. Next, please. So zooming into what Ethiopia's experience has been, as previously mentioned, Ethiopia has played an instrumental role in pushing the agenda forward in WHO 7216 with the emergency care systems for universal health coverage, framing the issue in more of integrating the care into the acutely ill and injured, following which we've managed to put this into our national 5-year health sector transformation plan, which has given due emphasis to the improving the care of the acutely ill and injured in realizing the health sector transformation goals, the universal health coverage, protecting people from health emergencies, contributing to the Warada or household transformation level, as well as improving the overall health system responsiveness, following which we've recently successfully launched the 5-year National Emergency Injury and Critical Care System Strategic Plan, which is also one of the mandates of the member states, which has actually been hosted. We've also managed to have the injury care as part of the essential health service package, so that we'd have the sustainability mechanisms in place. We're also developing the trauma roadmap for the next 5 years, which will also be launched in a short while. Next, please. So considering the GATE activities, the basic emergency care course has been implemented in a countrywide approach. Over 3,000 frontline providers have been trained, 224 health centers have been covered. We're, as I mentioned earlier, we're doing a concentrated impact monitoring and evaluation on the effect of the BEC toolkit on patient outcome and the delays and other process improvements in the 10 hospitals. We've also strategically included facilities which are located in trauma corridors, high trauma corridors, and have linked the BEC training with these facilities so that we actually can improve the care of the injured. And we have positive experiences so far, which we're also, one of which is also documenting the lessons. We also plan to have universal coverage of all the primary healthcare units by 2025, making sure that we have all the centers, the primary healthcare units covered with the BEC course. And we've also managed to integrate that as part of the health center reform guidelines, so by which the health facilities are being assessed. And it's going to be sort of mandatory for all health centers. Next, please. We have also coined this Major City Emergency Injury and Critical Care Improvement Program, which is a collaborative program between the academia, the university hospitals, the regional health bureaus, as well as the other different stakeholders within the city. As you know, major cities are the ones which are very prone for injuries, and we have to have strong multi-sectoral coordination, collaboration, and integration at the ground level. So we've managed to implement this in 6 cities with remarkable achievements in the last 1 year, with the integration of ambulances into a call and dispatch system, having technology input in this regards, and also extending this care from the community into the facility-based emergency care, as well as critical care for the acutely ill and injured. As you can see in the slides, we have structures addressed. We have people recruited doing only this, and also doing the remote consultations for intensive care units as well. Next slide, please. So these efforts also extend to the community. Massive community first aid responder trainings have been conducted. Over 3,000 community members have been trained. Toll-free access and ambulance dispatch system has been initiated. The trauma registry implementation is also initiated in these 6 sites. We've also managed to include all the revisions and make sure that the important data elements are included in the national data sets, so that we have the necessary data which would improve the care and also show the impact and the burden of injuries at the national level. We've also managed to link the disaster management system with facility surge capacity and citywide coordination. Simulation exercises have been done in these 6 major cities, and that has significantly improved the care of the injured, considering the
the recent conflict-related mass casualties within the country. We have also digitalized the referral linkage and also renovated emergency units, ICUs in these six major cities. We also plan to have not only focus on these 6 major cities, but have these all efforts, concerted efforts throughout all tier systems, system facilities in the existing 6 cities. Quality improvement projects are also underway. Next slide, please. So we've had, of course, several challenges during these activities, the above mentioned activities. COVID-19 pandemic has been a great challenge, and other health emergencies within the country have posed significant challenges on the way we operated, but it also brought up a good opportunity as well, so that more attention and light has been shown into improving emergency and critical care services, which all would have impacted the care of the injured. Data is also a challenge in our setting. Coordinating the different data elements, the data timeliness, quality, those are all the challenges. Limited resources for universal rollout of the BEC toolkit. We've done that in several of the waradas, which have the health centers, but resources have been an issue. Lack of sustainable funding, especially for injury care, has been a challenge. Supply chain for emergency drugs and equipment, and also insufficient multi-sectoral engagement at different levels have been some of our key challenges. Next slide, please. So considering the lessons learned, we've learned heavily that building leadership and political buy-in is very, very important. As mentioned earlier, our former minister has been very instrumental in pushing the agenda forward. It was the minister's decision to roll out the BEC to allocate budget and roll out the BEC course throughout the country, and also continuous advocacy in several sessions have been very, very important. And also developing, we've also had a budget approved for strengthening of pre-hospital services within the country. So the current minister is also on board, and also this has been the major city initiative, and the pre-hospital pilot have been the flagship initiatives of the ministry. And also those also have helped us in spreading the word in different multi-sectoral agencies in different platforms across the country and outside. Linkage with other programs we've found that very, very important, because talking the language, especially creating the why from the other perspective, and making the case that improving the care of the injured serves better for the pediatric care, for the obstetric care, that the government is also working on. And also it would also improve the sustainable development goals and other targets in other sectors, in the transport sector and other sectors as well. So that has been very shown to be highly impactful in our setting. Strategic communication and advocacy has been very, very key. We used all platforms, every opportunity to advocate for the care of the acutely ill and injured in whatever ways, especially using media campaigns, storytelling, and other personal experiences as well. Engagement of academia has been very key and instrumental. So getting the right data, publications, having a customized high impact interventions, and integrating that within to advise policy and decisions at the strategic level, at the regional health bureau, as well as the ministry level, has been very key. And also with what we did with the MEICIP, the major city platform, is that we have created a positive competition across regions for improving the injury care. So we've given them a list of thematic areas across the acute care continuum, and it has been a remarkable achievement what they were able to do within only 1 year, having all the concerted resources, having the pre-hospital systems established, and also several capacity building activities have also been achieved. And also access has also been created for patient care and also quality improvement. Delays have been shortened and such. So these have been the lessons learned, and we also continuously working on amplifying the gains and continuously learning for improvement. So we'd like to also learn a lot from other countries, broaden the network, and also getting experience sharing from other settings, because we don't have to reinvent the wheel, and also integrating this into other embedding it into other quality improvement projects within the country to show impact. Next slide, please. So moving forward, now that we have the clear 5-year, we have a clear roadmap, posted country action plan for emergency injury and critical care. Would like to have the continued implementation of the roadmap for Global Emergency and Trauma Initiative, pre-hospital pilot, the trauma registry implementation, the major city program, and also cascading all this, the strategic objectives, and integrating the mass casualty management, and also building the overall trauma system within the country is also planned activities. Providing versatile and resilient workforce at all levels is also given the key priority. Innovative financing, especially when it comes to emergency and injury care, is still the progress is encouraging, but it's still underfunded, underfinanced. So we're trying to look into third-party insurance mechanism schemes for the care of the road traffic injured, and also integrate efforts with other agencies with the joint action plan moving forward. And also evidence generation, the acute care continuum has also been given due emphasis. We have managed to have the data sets revised, and also plan to work collaboratively on different research, implementation science in different regards. Partnership and collaboration is very, very key, and ensuring sustainability of efforts have also been given due emphasis. I'd just like to highlight that with the strategy, we've boldly mentioned that reducing the incidence of injury with collaborative efforts from other sectors, and mainly focusing on the morbidity and decreasing the mortality and disability from injuries has been given due emphasis, and hopefully we'll also be working in this regard with other stakeholders and partners included. Thank you so much.
Thank you very much, Lee and Dr. Ghebreyesus. There was a lot in there. And I'm sure when we come to the question and to the discussion, we'll be able to then really get into it and inquire. So it was great to see Lee provide an overview with the resources that are available in WHO, and then see the real examples of people that have walked the talk in Ethiopia. We have one more presentation, and then I'll hand it over to Claude to walk us through the discussion session. The presentation that we have coming up is by Professor Charles Mock, and I'll quickly introduce him. So Charlie has training both as a trauma surgeon and an epidemiologist. He worked as a surgeon in Ghana for 4 years. And from 2005 to 2007, he served as the director of the University of Washington's Harborview Injury Prevention and Research Center. From 2007 to 2010, he worked at WHO in Geneva, where he developed the WHO's trauma care activities. In 2010, he returned to his position as professor of surgery. And his main interests include the spectrum of injury control, so surveillance, injury prevention, trauma care. He has published more than 250 scientific articles, primarily on injury control in low and middle income countries. He's a past president of the International Association for Trauma Surgery and Intensive Care, and he serves as the associate editor for the World Journal of Surgery. He's also on the editorial board of Injury, International Journal for the Care of the Injured. So Charlie's presentation is coming up. Unfortunately, he was not able to join us live, but I'll ask if Godfrey can give us that presentation. Godfrey? Godfrey, are you having problems with our presentation? Claude, do you have it handy and you can actually, excellent. So stay with us, please. And after this, then we'll be able to discuss all three presentations.
Professor Charles Mock, and I'm here today to talk about systematic improvements for trauma care or trauma.
It's a little choppy at the beginning. It'll get better as we go along. Can everyone see the screen?
In this talk, I will cover a bit about what are trauma systems and definitions, then discuss progress made and what has worked with case studies from individual countries around the world, and then wrap up with a discussion about global efforts to build on these individual examples from individual countries and make more progress globally. A trauma system can be defined as all that a country or area has in place for care of the injured across the spectrum of pre-hospital, hospital care, and long-term rehabilitation. And for pre-hospital care, that includes care by bystanders and first responders, as well as formal ambulance services or emergency medical services. And for hospital care, it includes initial care, such as in the emergency department, and definitive care, such as in operating rooms or theaters and intensive care units and the hospital more generally. And then finally, long-term rehabilitation of injured survivors back to active life. The more that you can organize these activities and get them to work together and get individual institutions to work together, the more likely you will have successful outcomes. This type of organization relies on governance. It also relies on having adequate information to know how the system overall and the individual components are working, as is provided by surveillance. There is an extensive literature on the parts of trauma systems that have been worked with in high-income countries, with a lot of evidence that has been brought to bear about how different elements can be made to work together, such as in the pre-hospital setting, protocols and triage as to how to handle the most severely injured patients, and medical direction, that is the directorship of trained professionals such as doctors working with paramedics. And then in the hospital, trauma center verification, that is establishing criteria as to what individual hospitals at different levels should have in place for care of the injured, and how these are used and monitored as through quality improvement programs. One of the best sources of information for this, and there's individual countries have different criteria, but in the United States and Canada, one that has been used a lot, as very well recognized, is this publication, Resources for Optimal Care of the Injured, from the Committee of Trauma of the American College of Surgeons. Other components of the trauma system to work with include transfer agreements, ways that hospitals work together, and system-wide, the role of lead agency and the authorities given to them, and data to know how things are working, as with region-wide trauma registries. The more that you can enact these type of elements, that is, the more that you can better organize a trauma system, the better it works. And better organized trauma systems have been shown to decrease mortality compared to similarly resourced jurisdictions that aren't as well organized, to decrease mortality of all treated trauma patients by 15 to 20%, and especially to decrease medically preventable deaths. That's things like deaths from things we know how to treat well, isolated splenic rupture or airway obstruction. Better organizing trauma systems can cut such deaths in half. One great example of the role of such elements of a trauma system and their effect is from the Canadian province of Quebec, wherein over a 10-year period, better organizing the trauma system for the entire province brought down the mortality rate for severely injured patients by from 50%, about half of such patients died in the early 1990s, and with a series of measures, including better organization of the high-level or big trauma centers, pre-hospital guidelines, better organizing care at the small hospitals, level 2s and 3s. These steps over a 10-year period decreased that mortality substantially from 50% to 10%. So what would be the gains if we were able to better organize such care, trauma care globally? This slide shows a study that looked at that question, and it looked at the percent of all seriously injured patients defined as injury severity score of 9 or more, percent of such patients who die, so it's a case fatality rate. And this case fatality rate went from around a third in a high-income environment to about a half in a middle-income environment to about 2/3 in a low-income environment. At the time, Ghana was classified as a low-income country. If we could eliminate this inequality, if we could decrease the case fatality rates in low and middle-income countries to those case fatality rates experienced by injured people in high-income countries, we estimate we could save about 2 million lives per year out of the 5 million injured people who die per year. So there's a lot of reason to approach organizing trauma systems better. So trauma care resources are part of the reason why those inequalities exist. Inequalities in outcome exist because of inequalities in resources, such as logarithmic differences in the surgical providers available in high-income countries. This is surgical providers for 100,000, high-income countries, upper middle-income countries, low and middle-income countries, and low-income countries. And also decreased availability of physical resources. Sometimes low-cost items are absent just because of difficulties with organization and planning. Obviously these differences are in part due or in part reflect broader differences in entire economies or in the health sectors with, once again, logarithmic differences in what's available between countries at different economic levels. But despite these economic constraints, there's been a lot of progress made in a lot of individual institutions around the world, a lot of people working very hard to confront the difficulties and challenges of their own environments, and a lot of interesting information has come out showing these successful examples across the spectrum of pre-hospital care, hospital care, and system-wide improvements at countries at all economic levels. I'd like to give just a few examples of these. For example, in an ambulance system in the northern Mexican town of Monterrey, increases in the sites of ambulance dispatch increased from 2 to 4, and there was improved training of the paramedics in the form of universal use for all paramedics of use of the pre-hospital trauma life support course, a short in-service training course. And these measures decreased the mortality of transmitted trauma patients from 8% down to about 4%, almost cut in half, at a 16% increase of the budget of the emergency medical services, something that was felt to be very sustainable within the local economy. And if we look globally, the vast majority of injured people in the world do not have access to formal emergency medical services. They're cared for in the field by friends or relatives of Good Samaritans. And a great project, a study that was carried out in multiple areas of the world by the Mine Survivors Foundation looked at ways to improve care even in very remote areas, post-conflict areas. And one particular study looked at northern Iraq and Cambodia and instituted a system that involved training of thousands of lay first responders with first aid, basic first aid training, supplemented by a smaller number of more highly trained paramedics. These providers were given training and basic supplies, but this project did not fund ambulances, and injured people continued to be taken to area hospitals by private vehicle and public transportation as they had before. Nonetheless, with these simple measures, mortality was decreased substantially from 40% down to 9% for mine blast victims and victims of other trauma in the area. And in the hospital setting, this particular quality improvement program in a trauma center in Thailand identified a high rate of medically preventable deaths from correctable problems like inadequate resuscitation of shock. They took simple corrective actions such as increasing senior staffing in the emergency department at peak times, and this resulted in a decrease in the mortality of all admitted trauma patients at that trauma center. I've already discussed the Quebec example, showing that even in high-income countries, oftentimes improvements are needed. Resources, though available, are often utilized incompletely or inadequately, and better improving the organization and planning can have substantial improvements in outcome. And I'd also like to point out that there are several low and middle income countries I'm familiar with that have taken similar steps. For example, a great example is the country of Sri Lanka, where there's a nationwide trauma secretariat that includes representatives of professional organizations working with the Ministry of Health in the same spheres of action that I just showed for the Quebec example. So a lot of good examples from around the world. How do we build on these individual examples and make more progress globally? Well, I'd like to mention a bit about the role of the World Health Organization, which has worked collaboratively on some guidelines for global trauma quality improvement, trauma system guidelines, together with the professional society, the International Association for Trauma Surgery and Intensive Care, which is a non-government organization, a professional society similar to AO. So there's a big role for this kind of collaboration, the World Health Organization and governments with professional societies. These various guidelines that I show here, guidelines for central trauma care, pre-hospital trauma care systems, and guidelines for trauma quality improvement programs, overlap with the guidelines that you've just heard about in the prior talk from the World Health Organization. All of these delineate resources necessary to provide basic essential services to all injured people, human resources, physical resources, and administrative mechanisms. For example, in the pre-hospital case, these guidelines give guidance to governments as to how to improve existing first responder care and how to improve or start and build up basic ambulance services or formal EMS. The guidelines for hospital care, similar to what I showed, similar in spirit to the guidelines established by professional societies such as the American College of Surgeons, but are oriented for the realities of ministries of health in low and middle income countries, which have sometimes single digits or hundreds of US dollars per capita per year to spend versus thousands in high income countries. These guidelines, at least in the hospital example, cover a range of facilities from clinics to small and big hospitals and show what is essential, or D for desirable, across 200 elements of skills and equipment. And just by way of general examples, looking at a low-income environment as an example, all rural clinics caring for injured people should have capabilities for rapid basic first aid, which many do not, although in many rural areas, such as in Africa and Southern Asia, these facilities care for a large number of injured people, sometimes providing the only care they receive. Small hospitals should have capabilities for chest tube and airway maintenance and certain minimum blood transfusion capabilities. Tertiary care centers should have capabilities for endotracheal intubation and in the emergency, on an emergency basis, which sometimes is very problematic, and should have basic quality improvement programs, which are often lacking. These guidelines from the WHO and IATSIC have been utilized in many countries around the world for needs assessments, development of educational programs, and healthcare policy. In terms of needs assessments, these have been carried out in dozens of countries, and in some have prompted and been a stimulus for action, such as in this great example from Dr. Nguyen Tay Sun from Hanoi, Vietnam, who used the guidelines to document efficiencies and promote improvements in trauma care in the network of hospitals in Hanoi. And these guidelines are increasingly being referenced and utilized in the formulation of national health policy, especially in Latin America. And one of the things that these needs assessments have shown is, in addition to individual need for improvement of certain specific equipment or supplies or elements of training, these have also shown a very low level of development of trauma quality improvement programs across hospitals. This is just an example from 4 countries, Ghana, Vietnam, India, Mexico. At the time of the survey, almost no trauma quality improvement activities going on, even in big hospitals. And this sort of finding prompted WHO and IATSIC to develop the guidelines for trauma quality improvement programs, which emphasize simple, broadly applicable techniques such as getting more out of morbidity and mortality, or M&M conferences and meetings, such as with more rigor in the form of preventable death panel reviews, and no matter what way you identify problems, taking corrective action to fix them. One example of a model trauma quality improvement program is some work done by Dr. Dominic Iboa, currently Chief of Orthopedics and Traumatology at the Kampuanachi Teaching Hospital. And he developed, carried out such preventable death panel reviews intermittently over a 10-year period, periodically over a 10-year period, and document and use these to decrease the preventable deaths, which did decrease during this period. The frankly preventable deaths decreasing from 25% to 13%, in part due to improved shock resuscitation, inadequate resuscitation decreasing from 17% to 18%, and in part also these decrease in preventable deaths due to improvements in the broader trauma system in the area in Ghana, with decreases in pre-hospital delays. So in conclusion, there is much mortality and disability that could be addressed by improved trauma care, especially by the improved organization and planning that are encompassed in the concepts and techniques of trauma systems. And these improvements are possible even in the lowest income, most difficult post-conflict settings, and improvements are needed even in many wealthy areas. The WHO and IATSIC guidelines are a way to increase progress in trauma systems globally. Thank you very much for the opportunity to present these results.
So thank you very much. In absentia, Charlie, we've really run way past our time. I'll hand it to Claude and see how best you can use the remaining time. Claude, over to you.
Thank you very much. I'll pick a couple of questions, and probably the first one will be directed to Taya. This is from Patrick. Patrick says that in Rwanda, they've witnessed tremendous road safety progress, but there remains challenge in many other African nations. And he's asking, what do you see as the key bottlenecks identified? in advancing road safety? And how can we figure out solutions to propose to the countries? And how does this tie to the political will? So Talia, if you could have a quick crack at it, maybe limit your answer to a few minutes if possible.
I think he's actually sort of summarized the answer, and the challenges, I actually did mention them in my presentation, so I won't go over them again. But I think the two key things: political will, and I think the advocacy aspect. Rwanda is clear political commitment to moving the road safety agenda on, and so you can see it working in a country like Rwanda. In other African countries, I think the reality of the problem has not sort of set in as much as it should at the political level, and so my thinking would be a lot more advocacy done. Again, a lack of data also makes it seem as if the problem is not as the data. We'll see the figures looking more dire, and I think that will also help in our advocacy perspective. But on the positive side, over the past 4 years, I've been working quite systematically, and there has been improvements. And I think that which is being put out by the African Union, and some of the work which we're trying to do under this observatory, where we're trying to start monitoring the decade and start what's happening in the future. Thank you.
Thank you. I'd like to ask Dr. Alankta to answer this question live, because I think it's an excellent question, and it always relates. I mean, no matter how much we try to do systems changes and systems implementation, we have to find the money. And Muzafiki asked the question of, what are some of the innovative financing strategies for emergency and injury care that you have been working on, at least in Ethiopia? I know you quite well, and have followed how things have evolved in Ethiopia. I know you've answered in the chat room, but I'd like you to answer live, please.
Thank you very much, Dr. Claude. It's a very important question, as you mentioned. We're still a work under progress. We don't have all the answers, but we're trying to look into sustainable financing schemes in which we include the care of the injured with the existing financial schemes, with one of which is essential health service package has also included injury as an essential care. So the health insurance scheme is expected to be covered in the health insurance scheme with a sort of cost sharing mechanism. We're also trying to look into the third-party revolving fund, which provides free access for at least the 24 hours emergency service for the for the injured, the victims of road traffic injury. We're also trying to look into ways to have percent dividends from other sectors, being the construction sector, the transport sector. They run many mega projects, and we're trying to lobby and advocate that part of the investment should go into building mobile health, hospital health units, having advanced ambulances, also investing in facility-based services to improve the care of the injured and such. So it's still a work under progress, and we're also trying to look into showing the data for more allocation of funding through the government system, as well as active grant writing, active resource coordination, coordinating of available resources through the academic links and other sectors, and also looking into community contributions in this regard. But so still work under progress, but we're trying to figure this out.
Thank you. There's a great question with regards to how do we attract funding and attention to the neglected epidemic of injuries, but this would be an entire new webinar. And I'll ask Taya one last question as a close, and then I'll just say a few comments and turn over to Olive for wrapping it up. It has to do with seatbelt laws. I mean, I remember quite well in 1976 in Quebec, which is my home province, when the seatbelt laws came into effect. And the question is, you presented that there's 15 countries that have seatbelt laws, but what about the software? I mean, the last time I got into a car in Africa, which was about 1.5 years ago, Well, there was a seatbelt law in that country, but I couldn't find the damn seatbelts in the car. So what can be done? How can countries that have laws, I mean, where's the software? How do you not only enforce the laws, but enforce the car makers and the legislation with regards to making the cars roadworthy so that there are seatbelts available? I mean, Quebec now and Canada, most high-income countries have one occupant, one seatbelt. Taya, briefly.
Yes, a challenge, but I think there's some countries which have sort of stepped up to the challenge and are working on it. And that it comes again to one of the issues that I was talking about, this motorization management. So we're not only looking at the side of the seat belts itself, but the side of the vehicle. So what vehicles do we import into the region? Well, the vehicles imported, do they have the seat belts in place? If they don't, they should not be allowed into our region. And then on the other side, when the vehicles are there, our vehicle inspection systems need to be more robust. When you go the annual inspection systems, the seatbelt checking, the quality of the seatbelt, the availability of the seatbelt should be part of the things that they look at to either pass the vehicle or fail the vehicle. So there are ways of doing it. I've seen it moving up in some countries. Some countries are looking more systematically at seatbelts. Again, but I think that the beginnings are having a law in place, because with the law in place, then you can start implementing based on the fact that you have that legal backing to get things done. And it just needs to be consistent and worked at on a day-to-day basis.
Thank you very much. My final words, and then I'll turn it over to Olive for closure, is the trauma systems are an extremely important part of NSOAPs. You all know what the NSOAPs are, and there's 6 key areas that all of the speakers touched upon that need to be addressed. 1 is the infrastructure. 2 is the workforce human resources. 3 is the service delivery. 4 is the information management and the data. 5 is the finance. Finance should probably be number 1. And last but not least is what I call leadership, government, regulatory, policies, and laws. So that's a handful. I want to thank all the speakers for making contributions to these 6 key areas. I'll turn it back to Olive for the final words. And thank you very much to all the participants for showing up and putting up with us. Thank you. Olive, mute.
Thank you, Claude. Yeah, our time is well spent, and I think to do justice to all of the questions that have been asked and to really interrogate these subjects, we'd have needed like half a day. We don't have half a day. In fact, we're out of time. But I think all of the speakers have given us food for thought and for an encouragement that actually, even when we have limited resources, a lot can be achieved. Definitely a lot of resources that are available that are not being well used. And I think we've had an excellent example from Ethiopia that those resources can be used even in limited, even when we have limited resources. So I'd like to thank our panelists, excellent panelists, for the time you spent. I'd like to thank everybody that has participated in this. I apologize for those who've asked excellent questions that we didn't have time to answer, but I'd like to encourage you to reach out to the panelists and follow up on these questions. So thank you very much indeed, and have a wonderful evening.
Bye, everyone.
Bye.
Thank you.
Bye.
Thank you very much, everyone. Bye-bye.
Bye.
Bye.